Hello, everybody. This is chapter 36 in Med-Surg, and this is urinary system function and assessment. And please look at the PowerPoint along with the lecture. So in this chapter, we're going to cover the normal anatomy of the urinary system. We're going to talk about the function of the system and its parts. We're going to talk about aging and the effect that that has on the urinary system, data collection, which is part of assessment. We're going to talk about your role as the nurse with regard to procedures. So what you need to do pre-procedure, post-procedure, nursing care for patients that are incontinent. And we're going to talk about what we can do to decrease the risk of urinary tract infections for patients that do have catheters, okay, because that is a big deal. So with the urinary system, what do you have? You've got two kidneys, and each kidney has a ureter that comes from it, which is a tube leading to the urinary bladder, which is just a storage tank. And then from the urinary bladder, another tube called the urethra, which is where your pee exits, okay? And everybody should know that. When you look at the interior of the kidney, I'm not going to go into every single part of the internal anatomy of the kidney, but I do want you to know when you're looking at slide 5, the renal pelvis is kind of right at the center of the kidney, and it's the last stop before the ureter. The renal pelvis actually becomes the ureter, okay? So as the kidney is making urine, which it does all day long, all day and all night, the urine is leaving the kidney through the renal pelvis, through the ureter, and going down into the urinary bladder. And why is that important? You'll find out later. Just know that the renal pelvis rather, can only hold up to like maximum about 30 mils of urine. And that's not a lot, right? That's a little bit, okay? When we talk about the nephron is the smallest functioning unit of the kidney. That's the thing that we kind of kick into overdrive when we give diuretics that are loop diuretics, for example, like Lasix and Bumex, furosemide, and bumetanide. Okay, that's the actual thing that makes the urine. And so what do the kidneys do? Whenever I ask this question, I get the answer, they filter. And they filter. So they filter your blood and they make urine. And urine is how we excrete waste. So when they filter your blood, they're taking the toxins out of the blood and they're turning them into a product that is called urine, okay? But they also either excrete or conserve fluid. So they manage fluid balance, and by doing that, they manage your blood pressure. They also manage your electrolytes. They also manage your acid-base balance. They also activate vitamin D. They make erythropoietin, which you must have. They make erythropoietin and send it to the bone marrow so that you can make red blood cells, right? And they also produce something called renin, and that's part of the renin, angiotensin 1, angiotensin 2, aldosterone, antidiuretic hormone system that goes on in the kidneys with the endocrine system at all times. And I'm not going to get into glomerular filtration, but just understand GFR, the glomerular filtration rate, is something that you will see on a laboratory request sheet. And basically that number is, it's a number that says how long does it take for the glomerular apparatus in the kidneys to filter the blood and make it into urine. And if it's too slow, that would be an indicator of a kidney problem, okay? So we already talked about the ureters and the bladder and the urethra. Let's talk about urine, okay? The average adult makes about 1,000 to 2,000 milliliters of urine in a 24-hour period, okay? When you look at urine, it should have color to it. It should not be clear, in other words, colorless. It should be a pale yellow to an amber color. It should not look dark like tea or cola, okay? But it should be pale yellow to amber. The appearance should be clear. In other words, when you look at urine in a urine cup, you should not see things floating in its sediment, that type of thing. It should appear clear. The specific gravity of urine is the urinary equivalent of the hematocrit to the blood. The hematocrit of the blood measures hemoconcentration. How thick, how thin is your blood? Specific gravity of urine does the same thing. How thick, dilute, or how concentrate is your urine? And so that number you need to know, 1.005 to 1.030. And the lower the number, the more dilute it is. In other words, it's more like water. The higher the number of the specific gravity, the more concentrated the urine is, okay? When you are looking at a urine analysis, you should know that the pH of urine is on the acidic side, 4.5 to 6, give or take. And what's in urine? Well, it's mostly water. And then waste products. You're going to find urea, creatinine, uric acid. But you should never, 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 ever find protein, glucose, or ketones in urine, okay? Those are things that should not be in the urine. They are signs of a problem with the kidneys, okay? When we talk about aging, you know, there are things that happen with aging to every body system, including the urinary system. The renal mass inside the kidneys gets a little bit smaller, and the fastness, the quickness with which everything works inside the kidney starts to slow down, right? Bladder muscles can start to get weak. Bladder capacity can decrease. So in other words, you have issues of incontinence, right? That can occur. They don't have to. Do your Kegel exercises. And sometimes with people, the voiding reflex can become delayed. So in other words, they don't get that urge to void, and when suddenly the bladder is so full, and then they can have an accident, become incontinent. Understand that when we talk about kidney disease, you cannot live without your kidneys, okay? You can live with one kidney, but you got to have at least one, because your kidneys affect pretty much every other system in your body, okay? So when you're assessing a patient, you get their health history, pain in the flank area. Where is the flank area? It's right up above your buttocks in your back. That's where your kidneys are. Would you have burning with voiding, new onset of edema, which would show a fluid imbalance that could have to do with the kidney, shortness of breath, weight gain, all have to do with fluid. We want to talk about the patient's fluid intake, their functional ability, of course, their vital signs. And remember, your kidneys manage your blood pressure. So if you see somebody with high blood pressure, that occurs with kidney disease. Lung sounds that would indicate crackles, fluid overload, edema, fluid overload. Remember, when you're trying to assess fluid overload, the best indicator of a person's fluid balance is a daily weight, not weekly, daily, okay? Every day, same time, same scale. And of course, you can do eyes and O's. And you want to look at the patient just in general. What do they look like? What is their coloring? Do they have a yellow or grayish tinge to their skin? There's something pretty cool that's called uremic frost, and you can Google image it. When the kidneys aren't working properly, all those toxins that are supposed to be getting excreted, well, they're spilling back into your bloodstream. And when they do that, you get something called uremic frost. It almost looks like you've been out in the ice and snow. You're covered with what looks like frost, but it's all those toxins, azotemia, all those toxins are just leaking through your pores. Lab tests. Well, urine analysis, okay? It's always best if you can to get the first morning specimen. A midstream clean catch specimen is the best. In other words, you instruct the patient, they're to clean the genitalia, they are to start urinating in the toilet, and then they are to get it midstream, okay? You only need about 10 milliliters of urine. And if you're not going to get it to the lab immediately, you should put it in the refrigerator, okay, just so you know. A 24-hour urine. This is important for you to know. And these are tests that are done to determine things like endocrine problems, typically, or very significant renal problems. So the doctor may say, I need a 24-hour urine. So you're going to instruct your patient to void and discard the first urine, and then you're going to record the time. So let's say it's 11 o'clock. So every time they void, the pee that they void needs to be added into this jug, this collection device. It kind of looks like a big yellowish jug. And if they miss one urine, oh, I forgot one, then that means it's not accurate and the whole thing becomes null and void and they have to start over. So 24-hour urine, they discard the first urine, record the time, and 24 hours, every time they pee, the urine gets collected and put into this jug. They miss one, null and void, okay? And then we could do a urine culture. You may hear the doctor say, get me a UACNS, urine analysis, culture and sensitivity. So, culture is a culture. We're looking for bacteria or something present in the urine that is causing possibly an infection. And the sensitivity tells us, well, they have E. coli. Sensitivity says, oh, you can use this antibiotic to treat E. coli. When it comes to blood work, you definitely need to know serum creatinine and blood urea nitrogen, BUN. Okay, and that's right there on slide 21 for your viewing pleasure. There's something called contrast-induced nephropathy. In other words, I've damaged your kidneys because I've given you contrast dye to do a test and your kidneys couldn't handle it, okay? The biggest people at risk for this are people with diabetes because, as you know, diabetes mellitus is uncontrolled diabetes mellitus is one of the #1 reasons that people have renal failure. Okay, but other reasons could be renal impairment for something else. They're on medications that are nephrotoxic that hurt their kidneys. Okay, so just be aware of that. And you all know, for example, metformin. If the patient's on metformin and they're going for any kind of contrast dye procedure, a cardiac cath, an angiogram, CT scan with contrast, they have to hold the metformin the day of and 48 hours after. 2 days after the procedure. Otherwise, we put them in contrast-induced nephropathy. We can put them in kidney failure. Okay, make sense? If we suspect cancer, we can do a biopsy of the kidney. That would only be under extreme circumstances where we actually need to go take a sample of kidney tissue to take a look at it under the microscope and say, is this cancer? There's something called a KUB, and all that is an X-ray of the kidneys, ureters, and bladder. And with that, we can see things like tumors, obstruction, right, kidney stones. There's something called a pyelogram. It's an IV, contrast dye test. Okay, we inject the patient with contrast dye, and then it's a series of X-rays that show the contrast as it goes through the blood and then through the kidneys and gets cleared out of the blood by the kidneys, okay? You don't need to know retrograde or antegrade. That's unimportant, but you should know an IV pyelogram. So you would want to ask your patient, hey, are you allergic to shellfish or iodine? Also, are you on metformin, tobramycin? These are things that are nephrotoxic, right? Okay. You're always going to look at the patient's creatinine level, okay? And you're always going to force fluids after any test with contrast dye to help the contrast dye get excreted, okay? It's important to know. You have renal angiography, and whenever you hear angiography or angiogram, that should say dye. They're using contrast dye, and they're looking at blood flow, right? So they're looking to see the portal system that's going on right there in the kidneys. How is the arterial and venous blood flow? They're really looking at the arteries, the renal arteries. But you're always going to ask about allergies to shellfish or iodine. You're always going to make sure that their creatinine is within normal limits because otherwise they wouldn't be able to tolerate the dye. And you're going to make sure that after the procedure, push fluids so you can help them excrete the dye. When you talk about an endoscopic procedure, whenever you see scopic or scopy, like cystoscopy, at the end of a word, it means that we're putting a scope in somewhere. So a cystoscopy means that we're putting a scope in through the urethra. In other words, kind of like an indwelling urinary catheter. We're taking a tube through the urethra up into the bladder so that we can look around inside. Okay, we want to see, maybe we suspect that there's cancer or there's a tumor in there or something. And so, we need to know what's going on. So we want to go in and take a look. Patient could have an ultrasound done. Ultrasounds are they're like the bottom of the barrel when it comes to diagnostics, but an ultrasound can show us things like enlargement of the kidney or kidney stones or tumors, right? We already talked about renal biopsy. I don't want to get into cancer. I have a whole lecture that's just on cancer. Okay, so we're going to go ahead to urinary incontinence. Make sure you understand the definitions. Stress incontinence. You laugh, you sneeze, you cough, you pee a little bit. Okay, if you do your Kegels, and by the way, Kegel exercises can be done by men and women. And to do them, when you are urinating, you must stop the flow of urine midstream. Stop it and start it. And you do that several times a day, every day, you're going to have nice, strong pelvic floor muscles that help prevent incontinence. There's something called urge incontinence. That means that I got to pee so bad, I just can't hold it. So one of the things the patient can do is try to keep a diary or a log. You heard me right. A diary or a log to kind of look at, when are the times that I'm most likely to have an accident? Well, maybe I need to go to the bathroom before the accident happens. Okay. And then we have functional incontinence, which just means I have a problem with mobility or something psychological, mental, where I just can't physically get to the toilet. Okay, that's functional. So maybe I've got a fracture and I've got a cast on or something. And for me to get to the toilet is really a big chore. And so I may have an accident trying to get there. Then there's overflow incontinence, which means that the bladder just gets so full and I'm not getting the signal to my brain that I need to pee, and then it just can't hold anymore. And then total incontinence is just that there's no holding the urine, right? None. It's just total incontinence. It has to do usually with either something neurological or something psychological, but it can be physical as well. When we talk about urinary retention, that means that the bladder is getting over full, right? And so there are causes that are acute and chronic. Acute, anesthesia, your opioids, they cause urinary retention. Anticholinergic medications all have the potential to cause urinary retention. And then, I don't know, there's an accident or some kind of a trauma to the urinary structures that damages them. For men, the number one chronic cause of urinary retention is an enlarged prostate gland. It's BPH, benign prostatic hyperplasia, because the prostate cradles the urethra, and when the prostate enlarges, it squeezes the urethra. And so the man will complain about, I can't start the flow of urine. I try to pee and it drip, 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 things like that. And we're going to talk more about BPH a little bit down the line. Facilities like long-term care facilities love bladder scans, right? But in a hospital, typically the doctor will tell you to do a post-void or a residual straight cath. What that means is you have the patient pee, and this is important because this is a board question and ATI. So a residual straight cath or a post-void, you have the patient pee, and after they pee, you catheterize them. And then when you catheterize them, if you see anything greater than, say, 100, 150 milliliters of urine in there, that's too much. That means that there's something going on. They're not emptying their bladder. Okay, so typically you want to see nothing more than 50 to 100 mils of urine in that bladder. Okay. Indwelling catheters, Foley catheters. Okay, there are some justifiable reasons, but understand, an indwelling catheter is the number one reason people get UTIs, because you have just an open route right up the urethra into the bladder. If someone is incontinent or someone has a wound, these are not justifications for a catheter, okay, because they so badly increase the patient's risk for infection. If we need to, we must catheterize intermittently, which reduces the risk of infection. There's something called a suprapubic catheter, and that is an indwelling catheter that goes through an incision in the lower abdomen. In other words, right at the pubis symphysis. So typically, you'll see patients, say you have a patient that's a quadriplegic and they've had Foley catheters. Foley catheters are sized, so 14 French, and then after a while, they're going to need a little bit bigger, right? So 16 French, 18 French. So over the course of years, they get to a point where there just are not any sizes bigger for the catheter, and there's usually pretty significant damage to the urethra for people that have indwelling catheters in for years and years. So the solution to that is a suprapubic tube or a suprapubic catheter. And again, into the pubis symphysis, which is right here, directly into the bladder with a tube that goes to a urinary drainage bag. Okay. I think that's about it. So that's just a basic overview of the urinary system. We're going to go on to chapter 37, and chapter 37 is broken up into parts because then we're going to talk about renal failure and all those other fun things. All right. As always, see you next time. All right. Bye.